Hi, good evening. Thanks for joining us tonight. I'd like to welcome everyone to the GAP MASLD MASH Community Network meeting. My name is Krista. I will be your moderator today, and I'm very pleased to introduce our speaker, Brian Lamb, who's a PAC from Inova Health System in Falls Church, Virginia. There will be an opportunity to ask questions at the end of the presentation, so I would ask if everyone can hold their questions until the end of the meeting, and you can either ask them live or include them on the chat box, into the chat box. So Brian, it's my pleasure to turn the presentation over to you.
Great. Thanks so much, Krista. And thank you all again for joining me tonight. The topic of today's talk is going to be non-invasive testing. As you know, this is very important in looking at MASLD and fatty liver and MASH. Again, my name is Brian Lamb. I've worked as a physician assistant in liver disease for the last 18 plus years. I serve as Associate Medical Director of Research here at Inova's Liver and Obesity Research Program, just outside Washington, D.C. Also, I serve as chair of the APP committee of the Global NASH MASH Council, and I'm glad to talk to you all about NITs tonight. So if you'd like to use this QR code, you can record your attendance for this meeting. I think you've already registered. Some of your information is already in there. Also, if you would like to access a recording of tonight's meeting, as well as other videos and podcasts from other APP experts, you can scan this QR code. That will take you to the MASLD MASH Community Network, which is put on by GAP. As you may know, GAP is Gastroenterology and Hepatology APPs. It is a great networking opportunity for PAs and nurse practitioners. It's probably the largest group of GI-Hep APPs here in the nation, and they have great meetings. The meeting will be in September. The annual meeting will be in September in Las Vegas. I'll be there. It's a great time to just network with other APPs. Also on the MCN, you will see disease state education and the Resdifra promotional program from Madrigal. But it's going to be a great resource, so that is the QR code for that. So let's jump into a case tonight to give us some context. So this is Albert. He is a fictional AI generated by Canva, but he's a 65-year-old male with some obesity. His primary care doctor has been following him for some mild elevation liver enzymes for the last couple of years, and he has had an abdominal ultrasound, which shows some fatty liver. So this is your typical case that you will see from primary care. In terms of social history, he used to drink in his 20s, but he has not had any significant alcohol since then. In terms of comorbidities, he has most of the components of metabolic syndrome. He has type 2 diabetes, high blood pressure, and high cholesterol. When you look at his blood tests there in the top right, his labs, his triglycerides are good. HDLs, not bad, could be a little bit better. His hemoglobin A1C is not exactly at goal, so 7.2% could be better, but it's not horrible. His ALT has been elevated, maybe about 60 or 80 for the last couple of years. He's been screened for hepatitis B and C and autoimmune hepatitis and all those other causes of liver disease, and those tests were negative. On examination, he has some weight gain around the belt line or central adiposity, but there are no stigmata of advanced liver disease, so he does not have any spider telangiectasias around the chest wall. There's no gynecomastia or anything that really would tip you off to advanced cirrhosis. He's not obese. He's a little bit overweight with a BMI of 29. So can we stop here and just say that he has metabolic dysfunction associated steatotic liver disease, which is the long way of saying, fatty liver? Can we say that he has MASLD? Is that enough? No. So what is the crucial next question that we should all ask about Albert? That question is, does Albert have significant fibrosis, right? Because when people have MASLD, you can kind of break them up largely into two large categories, low risk MASLD or MASH or at risk MASH with advanced fibrosis. And the way that we are going to make that determination and do that risk stratification in 2025 is using these non-invasive tests, or what the AASLD has called NILDAs, non-invasive liver disease assessments. Conceptually, as you think about non-invasive tests or NITs, you can group them into two big groups. On the left, you have imaging-based non-invasive tests. On the right, you have lab-based non-invasive tests. And then, kind of in the middle, you have some combination of imaging and lab-based non-invasive tests. For tonight's talk, we will mostly be focusing on the ones there in the light brown. So if you look at the left, on the top left, you have ways for looking at the amount of fat in the liver. So if you do a transient elastography, that's measured as CAP. If you do an MR elastography, that's measured as PDFF, or proton density fat fraction. Depending on the software of your MRI provider, it might be a different name, but some sort of fat fraction. We'll go into the details more as we go on. When you're looking at liver stiffness, liver stiffness is a surrogate for fibrosis. So if you're doing VCTE, vibration-controlled transient elastography, that's one way to look at liver stiffness. And then there's the MRI version, MR elastography, and that will give you the liver stiffness, which is measured in kPa, or kilopascals. On the right there, you have your labs that you can order. FIB4 is the first step that is recommended by all the guidelines. And that's just, we'll talk more about that in the following slide. ELF is another test that you can order from most commercial labs like LabCorp and Quest. And that's a proprietary serum marker looking at the amount of fibrosis. And then you can kind of combine these two. You can combine imaging and lab NITs. So FAST is the FibroScan plus the AST. You plug it into your MyFibroScan app on your phone, and it spits out a number that will help you see whether there is at-risk MASH. MAST is the MRI plus the AST. Again, you plug it into the app and you get a number. MeFib is MRE elastography plus your FIB4, and that's, you have a cutoff for your MR elastography and your cutoff 1.6 for your FIB4, and based on that, you can either rule in or rule out MASH, significant MASH. So let's jump into the details here with the FIB4. So this, on all the guidelines, this is the first step, and usually this is the most appropriate for just general practice. So for primary care, endocrinology, cardiology, if they want to know whether a patient has a risk for advanced MASH or at-risk MASH, FIB4 is the way to go. It's not the most accurate, but it's easy and available, right? And it's free, because most patients have, AST and ALT available in their chart. Most patients will have a platelet count on your annual CBC. So you plug these things in, you Google FIB4 calculator, you plug these things in, and you get a risk score. So FIB4 less than 1.3 has a pretty good negative predictive value for excluding advanced fibrosis. When the FIB4, and just to keep things simple, my mantra is FIB4 above 1.3, send to me. That is, if the FIB4 is above 1.3, send to your GI or hepatology APP. That's if you want to see a lot of MASLD. You can get a little bit more, a little bit fancier and tell them, okay, if the FIB4 is above 2.67, that's a very, very high risk, and then they should definitely go to hepatology. But to keep things simple, I just like to say FIB4 above 1.3, send to me or your friendly neighborhood GI hep APP. And that's when you would go ahead, and if FIB4 is above 1.3, then you would get a second non-invasive test, and we'll go into that. In terms of cutoffs, so now this is the second NIT that you could order, and this is in some of the guidelines. This made it into one of the AASLD guidelines on non-invasive tests. On the focus recommendations for APPs that we published, ELF is in there. And ELF is basically, it's a measure of 3 direct markers of fibrosis. which, it measures kind of collagen turnover, and that's, TIMP, P3, right, N-terminal of the procollagen 3 and hyaluronic acid. But these are just breakdown products of fibrosis, and it has a pretty good sensitivity and specificity. The cut points that you'll see, and you'll see different cutoffs in different guidelines. Sometimes you'll see lower cutoffs, but the one I like to keep in mind, and the one that's on the most reliable guidelines from ASLD and from the Global NASH MASH Council, is an ELF between 10 to 11 is consistent with at-risk MASH, and that would qualify for liver-directed therapy. The actual numbers are an ELF between 9.8 and 11.3, but 10 to 11 is kind of easier to remember. When you get an ELF above 11.3, you need to start thinking about cirrhosis. So that's ELF. And if we have questions, we can come back to these later at the end of the talk. In terms of imaging NITs, you have at least 4 different types kind of shown in these graphics below. Starting from the top left and moving clockwise, you have TE, or transient elastography. That's using a sonogram probe to look at that kind of green box under the patient's abdomen. This is meant to be a picture of the patient lying on the table, and you're looking into the abdomen and into the liver. TE is the most commonly available. That goes by the brand name of FibroScan or HiSky, iLive Touch. There's different types. On the right, you have MR elastography, it's an MRI with a special paddle that they place on the patient's abdomen, and you get a much bigger area to be measured, and it gives you these colors. Red is a lot of fibrosis or a lot of stiffness. Green is a little bit better. On the bottom are less common types. There's point shear wave elastography on the far left, and there's 2D shear wave elastography. And essentially, that's like a normal ultrasound with the elastography on there, and you can get different areas of interrogation with stiffness. The main thing to keep in mind, most likely you're just going to see TE, like FibroScan, and some, most large urban centers or academic centers, your radiologist may have MR elastography. All of these elastography measures give you liver stiffness in kilopascals, but it's important to remember that the scales are not the same. So 10 kilopascals on TE is not the same thing as 10 kilopascals on elastography. For example, on TE, 20 kilopascals is consistent with cirrhosis, but on MRE, 5 kilopascals and above is consistent with cirrhosis. So just keep in mind that the cutoffs are different depending on the modality. But today we're going to focus mostly just on TE and MRE. So this is vibration-controlled transient elastography, most commonly known as FibroScan for a brand name. It is a non-invasive quantification of 2 physical biomarkers of the liver. It's a bedside exam, takes about 5 to 10 minutes. We've got one here in our office. And basically it gives you 2 data points. You get liver stiffness and CAP. So stiffness is correlated with fibrosis on a liver biopsy. I tell patients, you want your liver to be soft and flexible. If it's more stiff, that tells you that there's more scarring or fibrosis, or likely to be more scarring and fibrosis. CAP is controlled attenuation parameter. So that's looking at how the sound wave is attenuated by the fat in the liver. And so it correlates with the amount of steatosis or fat in the liver. And both of these are important when we're looking at MASH. Now, I will say that it is essential for GI-HEP APPs to be able to read a TE report. So don't, if you are ordering TEs from a radiology provider, don't be satisfied with just getting a report that has 10 kilopascals consistent with stage 2 or 3 fibrosis. Make sure that they send you the actual report that has 10 of these images. And MASH is going to define your career if you stay in GI-HEP APP. You're going to see a ton of MASH within the next 20 to 30 years. So you will want to be able to distinguish a reliable TE exam from a suboptimal test. Because if it's suboptimal, then basically you're flying blind. So first you want to know, are there 10 valid measurements? Usually the radiologist will not send you an exam if there's not 10 valid measurements. Basically, as you're standing there, as the radiologist or the operator is putting the probe against the patient's abdomen, as you click and get these data captures, sometimes if you're in the wrong area or you're not deep enough, you're not going to get a valid measurement. So you need at least 10 valid measurements to give you your median stiffness. So that's you have 10 numbers and the median is the one right in the middle. And so you also want to make sure that there's not a huge variety. You don't want to test where you have like a couple of 5 kPAs and a 30 kPa and a 75 kPa. You want all the numbers pretty close together, and that's measured by IQR over median, your interquartile range over your median, and that should be less than 30%. On your exam, you'll see, there's a field that says IQR over median, and just make sure that it's less than 30%, ideally less than 25. Most importantly, I think, APPs, we want to be able to look at the image quality, and here's one representation on the right. And essentially, you want to see parallel shear wave margins. You want to see that black line is nice and tight, and that those lines are pretty parallel. Most images are not going to be as clear cut as this. What you don't want to see is that image starts to spread out at the bottom, that it becomes like a cone. That's not a really great image. Hopefully you want to see that all 10 images are nice and tight and a black line like that. And sometimes if you get one image that's not good, I'll mentally kind of throw it out and just keep that in mind. So make sure you have nice tight lines there. And all this can generally be resolved by making sure that whoever is doing the fiber scan has done at least 20, 30, 40 fiber scans. If they're new to it, then you might want to just take your fiber scan results with a grain of salt. So that's VCT, transient elastography. There are some limitations. So liver stiffness can be falsely elevated if there's a lot of acute inflammation or cholestasis. So if your alk phos is really high, or if your bilirubin is high, or if the aminotransferases are over 100, if you have a patient, with labs yesterday that has an ALT of 250 or 100, I'll say let's not do a fiber scan. Let things cool off for 2-3 weeks. Similarly, if they tell me, oh yeah, we were playing golf yesterday and I had 5 beers, don't do a fiber scan. Cool off for 2 to 3 weeks and then do a fiber scan. Other things can affect the stiffness. If they've eaten within 3 to 4 hours, that will raise the liver stiffness. Same thing with alcohol use. Also, morbid obesity, BMI above 30, 35, that can make fiber scans difficult and slightly raise the liver stiffness, but it can make fiber scans technically challenging. If there's ascites, that can skew the results and make them difficult as well. Also, if there are liver masses, that can make it difficult to get an assessment of the unaffected parenchyma. So those are things, mainly just make sure they're fasting and haven't been drinking. I tell my patients, fast for at least 4 hours and don't drink alcohol for 72 hours before your fiber scan, at least. MR elastography, some of those considerations are also pertinent for MR elastography. So MR is not available everywhere, but if it is available, it is your most accurate imaging NIT. In terms of accuracy, when you're looking at the ability to rule in MASH with stage 2 or stage 3 fibrosis, what we call at-risk MASH, the positive predictive value of MRE was about 90% compared to just a PPV of 72% for transient elastography. So it is quite a bit better, in at least in some studies, but it's can be hard to get, and insurance can be a nightmare sometimes. But in general, I always start with transient elastography, and if I'm uncertain based on the transient elastography, or if I need more data, I'll try to get an MRE. Or if I'm ordering an MRI for other reasons, like looking for assessing a liver lesion, I will ask the radiologist just to throw in the MRE as well. And so what it is the patient goes in for the MRI. Before they go in, they throw this big plastic acoustic driver on the abdomen and makes a bunch of vibrations in there, and you get your elastography for liver stiffness. Again, MREs can be tricky if the BMI is over 40. They might not fit in the magnet. So you'll want to talk to your MRI provider about their specifications. Iron overload can also be tricky. Also, if they have non-compatible implants or if they have claustrophobia, hepatic congestion can also be an issue and insurance issues as well. But that said, if you can get an MRI, an MR elastography, that's helpful. I'll also say as well that if you're going to get the MR elastography, you should also ask for the fat quantitation because you want both stiffness and fat quant, because that can be helpful for knowing where your patient is now. And if you give them liver-directed therapy, that can help you in a year to know whether or not that therapy is effective. Um, so, um, so this is the MITs that we talked about, and this is a great reference to keep front and center. Thank you, Dr. Lumba, for publishing this. So basically, so we have those tests just to orient you as we go down. We've got FIB4, ELF, TE, and MR elastography. In the far left column, we have some of the components. Again, FIB4 is AST and ALT, and your platelets, and your age. I didn't mention before, for FIB4, the cutoff is if it's below 1.3, they're probably low risk. You'll notice that age is in the numerator for that FIB4. So if patients are 65 years old and above, you'll need a cutoff of 2.0. So if it's above 2.0, then you'd want to refer them on for further, or you want to further evaluate using other NITs to look for MASH. But for 65 and below, you can use a 1.3. Also, if patients are 35 and below, there's not a lot of great data. So for your young patients below age 35, use a different NIT like ELF or TE. In terms of ELF, again, like I said, if you order it from LabCorp Request, they might give you these cutoffs, but essentially anything above 9.8 is consistent with at-risk MASH. Between 9.8 and 11.3 is consistent with stage 2 to stage 3 fibrosis. For TE or FibroScan, below 8 is considered low risk. From 12 to 20 is your window for at-risk MASH. In the high teens, 18, 19, 20, all the way up to 75, that's consistent with cirrhosis. And then below there, you have your cutoffs for MR elastography. Ooh, I've got 6 minutes. So let's get back to Albert. So what should we do? Obviously, we're going to put him through this pathway and see if he has at-risk MASH. Here are his labs, and if we were primary care, we'd plug it into that FIB4. His FIB4 is above 1.3, so he needs to come see me. It's in that indeterminate range. He needs more testing. This is the AGA guidelines, courtesy of Dr. Kanwal and associate and colleagues. So basically, what they should do there in primary care is that they want to identify patients at risk. Really hone in on your type 2 diabetics, as the ADA just released last month or a couple of weeks ago. 2 out of 3 diabetics have fatty liver or MASLD, and 1 out of 3 diabetics have MASH. In your general population, 5% have MASH, but in diabetics, 1 out of 3, 33% have MASH. So you really want to screen your diabetics or anybody with a component of metabolic syndrome, or if you've got fatty liver on imaging or chronic elevation of liver enzymes without another cause. Do a FIB4. If they're FIB4 on that far left in step 3, FIB4 is below 1.3, then you're low risk. So go be healthy. See you. I'll see you back in 2-3 years to do another NIT. If FIB4 is above 1.3, send to me. Do another NIT, most commonly liver stiffness measurement. If it's below 8 again, go be healthy and see you in 3 years. If it's above 8, and certainly if the liver stiffness is kind of in that 9 to 19 range, 10 to 20 range, then you would want to consider that patient has at-risk MASH and consider them for liver-directed therapy. For Albert, we did the FibroScan. His stiffness, TE was 6.7, so that's below 8 kilopascals. He's low risk, so go be healthy. Get in your exercise, avoid your ultra-processed foods, don't eat too much, and repeat your NITs in 2 to 3 years. I would say if they have diabetes or family history of MASH-related poor outcomes like HCC, repeat them in 1 to 2 years. And that's what we will do. So again, thank you for joining me tonight. Remember, you can make the difference in your patients' lives. you can help patients like Albert get to another high school graduation without a belly full of ascites. So you really can make a difference. So get out there and start using those NITs. Again, there's the QR code on the right for a recording from tonight and for other talks from other APP experts. Thanks again for joining me, and I'll open up for any questions.